Hello, and welcome to the presentation titled Communicating with Patients and Families Around Antibiotic Decisions in Telemedicine. My name is Sarah Keller. I'm an Associate Professor of Infectious Diseases at the Johns Hopkins University School of Medicine, where I see patients in the hospital, in the clinic, and over telemedicine. I'm one of the leaders of this antibiotic stewardship project, alongside my colleagues at NORC at the University of Chicago and Johns Hopkins University. Should you have additional questions after the webinar, please note the Safety Program's email address is safetyprogram4telemedicine@norc.org. None of the presenters have any conflicts of interest relevant to this program. The faculty and the planners or managers for the Postgraduate Institute for Medicine and Johns Hopkins University have nothing to disclose. All disclosures for the entirety of the program are listed on the program website along with CME instructions. In support of improving patient care, this activity has been planned and implemented by the Postgraduate Institute for Medicine and National Opinion Research Center. Postgraduate Institutes for Medicine is jointly accredited by the Accreditation Council for Continuing Medical Education, the ACPE, and the ANCC to provide continuing education for the healthcare team. For physician continuing medical education, this live activity is designated for one AMA PRA Category 1 credit. This activity is designated for one AAPA Category 1 CME credits. For continuing nursing education, the maximum number of hours awarded is 1 contact hour. This activity is designated for 1 IPCE credit. Successful completion of the CME activity, which includes participation in the evaluation component, enables the participant to earn up to 1 medical knowledge MOC points and up to 1 practice assessment MOC points in the ABIM Maintenance and Certification Program. By the end of this presentation, participants will be able to effectively communicate with patients and families about appropriate antibiotic use in children and adults in a telemedicine setting. We will start by discussing some clinician perceptions around antibiotic prescribing over telemedicine. A common scenario faced by clinicians is a patient or family member requesting antibiotics. However, our perception of what we think the patient wants may not always correlate with what the patient actually wants. In a systematic review of 13 pediatric studies on parent-clinician communication and antibiotic decision-making, parental concerns were often misinterpreted as pressure for antibiotics, and perceived antibiotic expectation was a major source of antibiotic overprescribing. Additionally, there is a common belief that not receiving an antibiotic prescription translates into low patient satisfaction. The data here are somewhat mixed. One study of satisfaction in telemedicine showed a positive correlation between satisfaction and antibiotic prescribing for upper respiratory tract infections or URIs. Another study evaluating satisfaction scores for acute sinusitis encounters outside of telemedicine found that a primary care clinician was 2 times more likely to get a favorable satisfaction score if they had a good relationship with their patient. In the second study, antibiotics had no significant impact on satisfaction scores, regardless whether the patient saw their primary care clinician or another person in the practice. Another large study included 100 patients who requested antibiotics during an outpatient in-person encounter. Among these patients, there is no significant difference in satisfaction among those who received antibiotics and those who did not. Some clinicians also have a perception that it takes a lot longer to explain why an antibiotic is unnecessary than it does to provide an antibiotic prescription. One study of over 13,000 telemedicine encounters for respiratory tract infections found that visits that involved not prescribing an antibiotic took only about a minute longer than when an antibiotic was prescribed. Similarly, an adult outpatient study on encounters for URIs found that antibiotic prescribing was only marginally predictive of a shorter visit time. The bottom line is just because patients present to a telemedicine visit inquiring about antibiotics does not mean they will be dissatisfied if you explain why antibiotics might not be needed, and this explanation does not significantly prolong the visit. A focused history allows you to accurately assess for which patients need immediate testing and treatment versus symptom management and close follow-up, otherwise known as watchful waiting. Watchful waiting, which is allowing several days to pass prior to making further diagnostic or treatment suggestions, has been shown to reduce unnecessary test ordering in the outpatient setting. In 8 out of 10 randomized controlled trials, evaluated in a 2017 systematic review, shared decision-making for clinicians reduced outpatient antibiotic prescribing for URIs, an open dialogue around diagnosis, what to expect, and agreement about when to seek follow-up is effective to both reduce prescribing and increase patient satisfaction. By using consistent language, reasoning, and clear messaging, you will spend less time looking for justification and backtracking and more time listening and explaining. You can also build communication strategies into your triage systems. For those who work in brick and mortar or primary care practices, you can create communication workflows up front to reduce lower value visits. For example, you can put in place a nurse triage protocol to provide expectant management for patients with URIs instead of scheduling them for a formal visit. For those of you overwhelmed with patient portal messaging, developing approaches to respond to common infectious complaints asynchronously with streamlined communication can help you save time. For example, you can use a standard templated message with expectant guidance for patients with common infectious complaints, such as those available on the Safety Program's website. So, how can we best communicate with our patients? Just remember that patients want to be heard and patients want their providers to validate their feelings. Think back to a time when you felt like someone was really listening to you. Take a moment to reflect on some of the ways in which you felt heard. A 2013 overview of communication in medical consultations found that patients highly valued a genuine emotional connection in patient-clinician conversation. In essence, trust building and empathy are key. A 2020 qualitative review described the importance of understanding patient perceptions of antibiotics, of understanding and eliciting patient concerns and expectations, of reassurance, and of shared decision-making in reducing inappropriate antibiotic prescribing. 2 ways of quickly establishing rapport in the acute visit include maintaining eye contact even if needing to view a computer screen and summarizing the patient's story in their words. Even though eye contact can be a little more challenging with telemedicine visits, patients will be able to easily tell if you appear to be looking at them versus only looking at the medical record. If the patient or family member is not looking at the computer screen, you can also ask them to move the camera so that you can more easily make eye contact. Summarizing the patient's story in their words emphasizes that you are listening and synthesizing what they are telling you. In a clinical trial in 2020, pediatricians and pediatric nurse practitioners in 19 practices were trained in the dialogue around respiratory illness treatment, or DART, approach to communication. First, they would give a negative treatment recommendation. This meant a recommendation about why antibiotics were not needed. Then they were asked to follow this with a positive treatment recommendation. This meant specific advice about what treatments could help the patient's symptoms. Finally, the clinician would provide a contingency plan. This meant the clinician would provide advice about when and how to reach out if the patient was not improving. The DART intervention led to a 7% decrease in antibiotic prescribing for respiratory tract infections overall, and a 40% decrease in antibiotic prescribing for viral respiratory tract infections. Think about how you can quickly and efficiently use this approach to provide a negative treatment recommendation, a positive treatment recommendation, and a contingency plan in your interactions with patients and families. Let's go through 3 specific concerns patients often raise and potential responses. You are seeing a patient for bronchitis over telemedicine. She says, "My doctor always gives me an antibiotic for this cough." The problem is that another clinician had prescribed antibiotics for similar symptoms in the past. It is difficult to question the judgment of another colleague. Unfortunately, the other doctor may know the patient better than you do. It is important to validate the patient's feelings, but explain clearly how your suggested management is still in his or her best interest. Begin by sharing up-to-date information with the patient to indicate that you are doing what is currently considered best practice and confirming your focus on symptom improvement. For example, you could say, "There's newer evidence showing antibiotics have more side effects than we used to realize. These side effects cause 150,000 emergency department visits per year. We are becoming more careful about only prescribing antibiotics when they are really needed to avoid exposing you to unnecessary harm. I know you're not feeling well, and I can give you a few other recommendations that will help you feel better while you recover from this. You can then follow this with a few examples of over-the-counter cough suppressants, throat lozenges, and analgesics with dose and frequency. Give specific information like specific generic medications or sleeping with extra pillows for a few nights or considering a humidifier. This provides a negative treatment recommendation followed by a positive treatment recommendation. Your patient may ask, what are the side effects of antibiotics? You may say something like, there is a bacteria called C. diff that can cause bad stomach pain and diarrhea and changes the good bacteria in your gut, so you may continue to feel bloated and uncomfortable for several months, even after treatment for C. diff. You can also say, when people take antibiotics, the bacteria around us can actually get stronger and it becomes harder to fight future infections. The more careful we are about antibiotics now, the more we protect our families and communities against bad infections in the future. Your patient might say, but antibiotics are the only thing that has ever helped this cough get better in the past. It's possible that the symptoms previously improved because of other supportive measures or because of the natural course of bronchitis. This may have coincided with starting antibiotics, leading the patient to falsely believe that the antibiotics were helpful. A response to this might be to emphasize that it is a good thing that the patient does not need antibiotics, then explain why. Then shift the focus to steps the patient can take to feel better. For example, I understand that you feel terrible and coughs can certainly be frustrating. You most likely have a viral infection, and antibiotics actually don't work against viruses. This is good news because we want to avoid putting you at risk for the diarrhea or other discomfort that can come with antibiotic use. Let's discuss some other things that could help you feel better. You are providing a negative treatment recommendation and following it up with a positive treatment recommendation. As previously discussed, clear communication and an empathetic tone are better predictors of satisfaction than an antibiotic prescription. Let's discuss another scenario. The parent presents their otherwise healthy child for a telemedicine evaluation for an acute respiratory infection. The parent says, I had the same thing as my child and my doctor gave me an antibiotic, so I think he might need one too. In this case, it is important to first formulate a response that acknowledges the parent's feelings. Second, demonstrate diligence in evaluating the child prior to making your decision. And third, offer alternative options that might reduce symptoms. For example, you could say to the parent, I am sorry your son is also not feeling well. After thinking about his symptoms and the examination over telemedicine, it looks like your child has a virus. Antibiotics don't help viruses, and viruses are actually quite common in children. Most kids will bounce back quickly on their own, but here are some things that can help your child feel better. Follow this up with specific recommendations while also including realistic expectations for when the child should feel better and specific criteria that warrant a return to medical care. This way, you provide a negative treatment recommendation, a positive treatment recommendation, and a contingency plan. As you are evaluating the child over telemedicine, it is helpful to say out loud what is normal on the physical exam with positive adjectives. For example, his throat does not look red or inflamed. That's great. He looks like he is breathing comfortably. In a 2010 study of 522 pediatric URI encounters, parents were more likely to question non-antibiotic treatment plans when pediatricians made no comment or named only problematic findings, versus those encounters where normal exam findings were mentioned prior to a no antibiotic treatment plan. We have been talking a lot about how to communicate with patients and families about antibiotic use. There are a few suggestions about what not to do. First, don't discount patient complaints or symptoms. Instead of saying, your symptoms don't sound that bad, you can say, it sounds like your symptoms are really bothering you, to avoid making the patient or family feel like that you aren't listening to them. Second, avoid judging other clinicians' prior antibiotic decision-making. The situation now may be different. Furthermore, our understanding of antibiotics has changed. You may not want to say that other doctors shouldn't have given you antibiotics. If the patient had a close relationship with the other doctor, it may make the patient or family trust you less. In addition, focus more on the individual patient rather than just on antibiotic resistance, which may be an abstract concept to some. In a survey of 250 adults sitting in the waiting room of a family practice office, Statements focusing on global or local antibiotic resistance were not perceived to be as impactful as statements focused on the potential impact of antibiotics on the patient or those close to the patient. Some patients in the study were confused about what antibiotic resistance meant. So instead of saying, we need to give fewer antibiotics to reduce antibiotic resistance, consider talking about the potential side effects of antibiotics on the patient or on those close to them. As we mentioned, limiting antibiotic prescribing can cause clinician concerns about the potential of low patient satisfaction scores from surveys or in online social media-based reviews. We can improve patient satisfaction by demonstrating active listening, summarizing what we hear, and validating concerns. Provide negative and positive treatment recommendations as well as a contingency plan. As you think about culture change, consider displaying commitment posters. One study found a 20% reduction in inappropriate antibiotic prescribing when commitment to safe antibiotic prescribing posters were displayed with pictures of providers with their signatures. Perhaps you could show these commitment posters when patients are accessing the practice website or logging into their telemedicine portal. It's helpful to also remind clinicians of their commitment to safe antibiotic prescribing. You could display these commitment posters on the clinician's portal. Another important concept is senior leadership engagement. One specific proposal for your senior leaders may be unlinking patient satisfaction surveys from compensation and bonuses. The purpose would be to eliminate the potential influence of the satisfaction survey on antibiotic prescribing decision-making for a diagnosis for which antibiotics are commonly inappropriately prescribed. Consider showing antibiotic prescribing rates before and after if you can show reduction in inappropriate antibiotic prescribing, and then expand from there. To summarize, remember to listen without frequent interruptions so your patient feels heard and their feelings and concerns are validated. Provide positively focused messages about why it is a good thing that they do not need antibiotics, and provide concrete alternatives as well as guidance on when they should return to medical care. Remember to engage your leadership so that all clinicians and patients understand that your practice is dedicated to safe and responsible antibiotic prescribing. Together, you can remove barriers to appropriate antibiotic prescribing. Let's review your next steps. Sign into the program website, safetyprogramfortelemedicine.org, to review the webinar schedule for the upcoming webinars and office hours, and watch recordings of past webinars. You have already reviewed this webinar, but just to remind you, it will be available as a recording as well as a slide set with a script that you can download within 5 days following the second presentation on this topic. This month, there will also be several one-pagers available for download. You can review the one-pager on patient communication intended for clinicians and healthcare workers. Please consider also using the patient and family education materials. There is a discussion guide to review with your practice about how you and your practice will effectively manage patient communication around antibiotic decisions. Your implementation advisor will let you know when baseline data collection tools are posted to the website for you to complete. If you have not already, please complete the monthly check-in with your implementation advisor. They are your main point of contact and will work with you closely to answer any questions about the program, including help with website access and assistance with data submission or data quality issues. If you have any issues logging into the website or other questions, please contact your implementation advisor or the safety program at safetyprogramfortelemedicine@norc.org. Thank you for joining us for our presentation today. We invite you now to ask questions.